Hello guys, welcome to the INICT Ophthalmology 2022. I hope you are doing fine and chill. Every paper has some good and some bad, but the good thing is that ophthalmology was not such a great problem this time. So, hello guys, welcome to you know based on the recall whatever you people have provided us, and I have a lot of boggling and a lot of discussion with you people, with all the students, in getting the right options, and I tried to find out the right language, what actually the question wanted to ask. And because this time I think multiple answer type of questions was there. They say one only, one and two, one to three, and 1 2 3 4, something like this. So based on that we are there, but of course this is memory based, and I would be requiring your help in improving the language as well as options. So please keep on helping in that, so that I can come up with the most authentic questions. So starting with the first one, ophthalmological examination of a patient is revealing the orbicularis oculi paresis. Then there was a leg ophthalmos also, decreased sensations or the insensitive cornea. Which of the following infection is likely to be associated? So, can you correct me? Is this question correct? Is if the options are all right, we have Onchocerca volvulus, we have Acanthamoeba, Mycobacterium lepra, and Chlamydia A to C. So please help me in this, because now your bigger paper, the NEET is also there, so I want everybody to be little very very corrective in this. And because the right language will help us to give you the right options, and these questions are high yield for your NEET paper also. So help me in any of the corrections. This is correct. Thank you so much, Priyanka, Rashid. So this has been very well covered in the integrated session. I have covered ophthalmology with medicine in the leprosy. So if you look here, ocular manifestations in the leprosy, I have told you all the symptoms which are occurring in the lids. We have medorosis, we have got leg ophthalmos, even actropion, antropion is there. And because of this, leg ophthalmos, when you are not able to close the eye, there are chances of the exposure keratitis. And the decreased corneal sensations is a very well known sign of the leprosy. Then we have got so many things in sclera, episcleritis, scleritis, nodules could be there, even staphylomas could be there. And see, I have marked also. See, when I was teaching, even I have marked that these are the things which are really really important. See, one is your exposure keratopathy. Then even in the fundus, we also study about the iris pearls appearance in leprosy. So as expected, because we are expecting a lot of integrated questions, right? So I think, hi Swaroop, hi Vandana, Starry Sky, Aryan, Rashid, welcome to all. And I think this is a good question. Not a very easy one, but not googly as well. You very well know the sensations are decreased in the leprosy. We study leprosy, and we have done a integrated video also of the with medicine. And this was the flow chart that I gave you, all the eye complications in the leprosy. So I think this question is not a problem. Everyone is very very clear. Mycobacterium leprae with the answer is the answer, right? Okay. Then another important thing, the onchocerciasis. So that is actually not found in India. When I teach you the Vision 2020 program, I taught you very well that onchocerciasis is a part of Vision 2020 program, but this is actually not found in India. This is not found in India. So because this is not found in India, so instead of this, what we take in India is the retinopathy of prematurity and the diabetic retinopathy. And I think according to the age, retinopathy of prematurity obviously we will take in children, and diabetic retinopathy we will take in adults. So this we know that this is not common. Acha, then Another thing what they have given is acanthamoeba. So acanthamoeba, again we know that this is associated with basically ring infiltrate. When it comes to acanthamoeba, what are the words that we are looking for? We are looking for the word ring infiltrate or the ring abscess. It could be a ring abscess also. Plus we will have the radial keratoneuritis. Another important word will be radial keratoneuritis. Radial keratoneuritis because the nerves are in radial fashion. So the nerves are in radial fashion. We are having inflammation all over. So this is radial keratoneuritis, and above all, you will get a history of the contact lenses. You get a history of the contact lenses. So we are not having anything like that. When it comes to chlamydia, chlamydia is actually causing the blinding trachoma. So when it comes to trachoma, actually we have got two kind of trachoma, blinding trachoma and we have inclusion conjunctivitis. Do you remember if I talk about the chlamydia trachomatis? Okay. When I talk about the chlamydia trachomatis, we have got two kind of the subspecies. We have A, B, BA and C. So this is what they are saying, A to C, and then we have got D to K. So it is this A, B, BA and C which is actually responsible for the blinding trachoma. This is actually responsible for the blinding trachoma, while the D to K is responsible for the inclusion conjunctivitis. This is responsible for the inclusion conjunctivitis. Now when it comes to the inclusion conjunctivitis, again why I am explaining you these things, because you know every question is important for your need. So maybe this particular option was not the answer, but they can slightly twist the language and the answer will be different. So you have to be very very careful. Now inclusion conjunctivitis we can do in the adults also and in the neonates also. In the adults it's very very common in swimming pools. So this will be called as the swimming pool conjunctivitis. So this is your swimming pool conjunctivitis, while in case of the neonates this will be your neonatal inclusion conjunctivitis. So if a baby, a neonate matlab it will be less than 28 days. So if I am having a neonate less than 28 days, this will be presenting in the form of the ophthalmia neonatorum. This will be presenting in the form of the ophthalmia neonatorum. So all the options are clear and we are very clear cut with the answer of this question. Right, so this question is done. Question, options, answer, everything is clear. Okay, let's move to the next one. Okay, so let's move to the next one, guys. Right, so this is again I think a very good straightforward question. Which of the following is seen in the angle closure glaucoma? Which triad? I think because all the four triads they have given, which of the following triads is found in the angle closure glaucoma? So this again I have taught you that it is the slit lamp where you are going to find the Vogt's triad. So in cases of the primary angle closure glaucoma, it is the Vogt's triad that you are getting. What is Vogt's triad? Vogt's triad में we are getting number 1 is the glaucoma fleccens. Please check the language of the question, please check the options and please let me know if there is any change required. Glaucoma fleccens, this is the anterior subcapsular cataract that we are getting. Number 2, we can get the patches of the iris atrophy. Patches of the iris atrophy that we are getting, right? Then number 3, we also get the pigments on the corneal endothelium. So this is a very very important thing. We always read that acute congestive glaucoma is an ophthalmic emergency and this patient is presenting with the acute red eye. This patient is presenting with the acute red eye. What is the characteristic triad that I am going to get? So which triad is seen? Which of the following triad? Which of the following triad is seen in the patients of angle closure glaucoma? Options correct hai. Can you see? So this is a straightforward one. Acha, another important thing is that like they have asked you a straightforward question that which triad is found in angle closure glaucoma. This is also important a clinical scenario form. This is also important in the clinical scenario form of the acute red eye. So you have to be really careful for your NEET that it can present as a clinical scenario. So whenever you are getting a clinical scenario on acute red eye, when the patient is presenting with the sudden painful, when the patient is presenting with a sudden painful diminution of vision, or the patient is presenting with the acute red eye, what are the things you have to take into consideration? The first is your acute congestive glaucoma only. Then second can be your acute anterior uveitis. Then third we can have the chemical burns. We can also have chemical burns, and we can also think about the acute bacterial keratitis. Acute bacterial keratitis. These are the common things you are going to have in the acute red eye. Now one thing is there which is not acute red eye but actually it resembles. That is your acute hemorrhagic conjunctivitis. Acute hemorrhagic conjunctivitis. So if you are having a patient of acute hemorrhagic conjunctivitis, then that can also present with the acute red eye with a sudden painful diminution of vision. Now how will you differentiate? Because most of the time these are the two DDs, so you should have a consideration how to differentiate between the two. So let's take both. On one side we have acute congestive glaucoma and another side pe acute anterior uveitis. So I will give you 5 very important points how you can actually differentiate whether it is glaucoma or whether it is uveitis. Number 1, if I talk about the gender, so glaucoma will be common in females while uveitis will be common in males. Second will be the age. Glaucoma will be more than 50 years while talk of the uveitis, this is common in the young age. Okay? Then number 3, if you are having the glaucoma, you will have the stony hard eye. You will have the stony hard eye because IOP is very very high, and you will have the very high intraocular pressure. While if I am having the uveitis, I will have the aqueous flare, that is the earliest sign. I will have the keratic precipitates. And the fifth important thing which they will definitely give you will be in the form of pupil. You will have glaucoma mein, you will have the mid dilated pupil, while in cases of the uveitis we will have constricted pupil, fixed in both. Pupil will be fixed in both. So these are the 5 important things that will help you in differentiating the acute anterior uveitis and the acute congestive glaucoma. Yes, so are these options correct? Have you got the acute ophthalmic emergency? Treatment is not a problem once the diagnosis is clear. I think treatment is not a problem. Dono side pe you will have the circumcorneal congestion. Pupil is a great thing because pupil is entirely opposite. In cases of glaucoma, you will have mid dilated vertically oval fixed pupil. In cases of uveitis, you will have constricted pupil. It will be irregular due to synecdoche, and obviously this will be also fixed. So this question is also fixed. Question number 2. Now comes this. Punched out retinal lesions. Now there is a lot of confusion here in the options. First of all, please check if the options are correct, and also tell me was the question is that it is seen in, or was the question not seen in? Because I'm really doubting that they asked it is not seen in, because only one of the options per se here is actually showing you the punched out retinal lesion. So Swaroop, Vandana, Sakshi, all those people who are watching me, please tell me, did they ask it is found in or it is not found in? Because if you look at the options, I think options It will be resumed. It will be resumed soon. I think today and tomorrow we are doing the recall, and then we will be resuming the questions. Okay. It is seen in, because I really देखो अभी भी there is a mixed response कि it is seen in and it is not seen in, क्योंकि ना out of these only one option shows punched out lesions, and that is the toxoplasmosis. Only the one option. So I do not know how, if they have given not seen in, then how they have given, because posterior staphyloma definitely is not showing you the punched out lesion. Posterior staphyloma is the posterior ectasia. Posterior ectasia of the sclera that you get in cases of the high myopia. 100% है not seen in. तो I do not know. अगर not seen in है, then you have to go with the odd one out, क्योंकि posterior staphyloma ideally speaking is not a punched out lesion. Punched out lesion see is something like this. This is your toxoplasmosis. So this is the one that typically is called as the punched out lesion. So when you call it as a punched out lesion, it's a chorioretinal lesion which is having the what you call as the they asked not seen in. So okay, let's do it both ways. Punched out lesions में you are getting the punched out lesion as the chorioretinitis. Chorioretinitis. So see, punched out lesions is a definite term which is used for a series of the lesions where they are found the defects in the RPE level, choroid and the retina. So basically this is found out of these four options. It is actually found in the toxoplasmosis. Posterior staphyloma में what you are getting is the stretching of the eyeball, है ना, जो हमें मिल रहा है. This is the posterior stretching of the eyeball. This is called as posterior staphyloma that you get in the cases of high myopia or the pathological myopia. So ideally this is there. If I talk about the coloboma, now coloboma means you will get a round kind of a lesion where you will have absence of the tissue. Coloboma means you will have absence of the tissue. So that is also not called as a punched out lesion. When I talk about the rubella retinopathy, then this is typically a salt and pepper retinitis. Salt and pepper retinitis. And in the cases of toxoplasmosis, you will have typically headlight in the fog appearance. Headlight in the fog appearance. So this headlight in the fog appearance, basically what you are having here, this headlight is a patch of the chorioretinitis. This is a patch of chorioretinitis, and what fog? Fog is actually the vitritis. So this patch of chorioretinitis is actually a punched out lesion. So ideally what they should have asked is that it is found in, out of this it is found in the toxoplasmosis. Nevertheless, because even in the rubella also we do not get the punched out lesions. We get the salt and pepper retinitis, or we get the microphthalmos also we are getting, and then we get a cataract, the nuclear pearly cataract. So the kind of lesion what you are getting in retina is a salt and pepper retinitis. So according to me, the answer should be toxoplasmosis. If they have asked, it is found in. Now see the other things also. Basically, the most important cause where you get this punched out lesion is the presumed ocular histoplasmosis syndrome. We have to learn for the future. because this is not something which is usually asked and we are usually covering. So this is actually a presumed, that is your POHNS, presumed ocular histoplasmosis syndrome. There you are getting a very, very typical, this one, typical punched out lesion. So apart from the toxoplasmosis, another cause where you get a punched out lesion is your presumed ocular histoplasmosis syndrome. This is one. Then you have got wherever you are having the patch of chorioretinitis. So another is your tuberculosis, where you are having the posterior uveitis, granulomatous uveitis. तो toxoplasmosis भी है, histoplasmosis है, tuberculosis, sarcoidosis, see, syphilis. These are the things where you are getting these kind of lesions. Even they are also including the sympathetic ophthalmitis. So sympathetic ophthalmitis, again, it's a traumatic type of uveitis, but that is also a granulomatous uveitis. There also you can get it. Then a very, very important thing, you are having the two more short forms. You are having the MEWDS. This is your multiple evanescent white dot syndrome, the birdshot chorioretinopathy जिसमें मिलता है, very, very small lesions. There is also there. So you should know the full form now, multiple evanescent white dot syndrome. There you can again have. And another is your AMPEE. AMPEE. That is also there. This is your acute posterior multifocal placoid pigment epitheliopathy. Now we will not go into the details because this is a far beyond level of PG, but you can learn the names at least. Where you can have the punched out lesions, only learn the names where you can have. Yeah. Actually what happens now, the problem is when they give you the very close options or very absurd options. So question is not a problem. Some people are saying that it is found in, we are 100% sure, and some people are saying that it was not found in, we are 100% sure. So I cannot say about it. Obviously, you people have attempted it, and you people are right, whatever you are saying. But the thing is that we have to understand the concept, that if it comes in future, how you have to attempt it. So if it is found in out of these options, the answer will be toxoplasmosis. है ना. उसके अलावा wherever you are having the granulomatous uveitis, you will find it. And one more thing where you can get this punched out lesion is your tuberous sclerosis. That is called as the tuberous sclerosis complex. So for the future, you can learn these names. We have histoplasmosis, toxoplasmosis, sarcoidosis, syphilis, tuberculosis. Then we have got the multiple evanescent white dot syndrome. We have got the acute multifocal placoid pigment syndrome, and then we have tuberous sclerosis complex. These are the places where you can get punched out lesions. ठीक है, not a problem. Then okay. All right. So coming to the next question. Now this is again an important one, and I have a lot of feedback about this question which are differing. So there is a young female sudden we are having the young female, and this young female is coming with the sudden painless, young female with the sudden painless loss of vision, and we also have a RAPD present. Now if I am saying RAPD present, that means we will have some problem with the optic nerve. We are actually thinking about the optic nerve disease, and the other eye is normal, and I think some people also said that rest of the examination is normal. We are not having any other thing. Please check the language of this question, because this was a long clinical question, so I have a lot of doubt about the language of this question, and accordingly we will decide that which test we should do. Yeah, so I think this was a multiple choice question. What were the options? Like 1 and 2, 1, 2, 3, 1, 2, 3, and 4, something like this. What are the options that we are having? So, obviously, this is for sure. It is for sure, because if you are having a sudden painless loss of vision and RAPD is present, RAPD is actually the earliest manifestation. This is the earliest manifestation of the optic nerve disease. It is the earliest manifestation of the optic nerve disease. So definitely I am thinking on the lines of the optic neuritis. So definitely I am thinking on the lines of the optic neuritis. And if I am thinking on the lines of optic neuritis, definitely I will do MRI orbit and brain. Now, I had a lot of discussion with the other faculties also regarding this. So, why we should do the anti-NMO and the MOG antibodies. So, basically, this NMO antibodies are also called as the anti-aquaporin antibody. All of the above was also present, na? Yeah, so these antibodies are also called as, please write it, anti-aquaporin 4 antibodies, and these are actually there in the neuromyelitis optica. And what happens, these antibodies are definitely, related with the optic neuritis. We have got two things. One is this anti-aquaporin 4 antibody, which is involved in the neuromyelitis optica, demyelinating disorder है. दूसरा है MOG, that is your myelin oligodendrocyte glycoprotein. So this protein is also involved in the multiple sclerosis. This MOG glycoprotein is also involved in the multiple sclerosis. And we know that multiple sclerosis is the most common cause of the optic neuritis. This is the most common cause of the optic neuritis. So we have to do these two also, anti-NMO as well as MOG antibodies also. Now what do you think? Should we do thyroid profile? So we were having a discussion about the thyroid profile. Actually, thyroid can also lead to the compressive optic neuropathy, right? And if you see that there is a common dictum, I found out all the tests that you should do in the patient of the optic neuritis. Basically, optic neuritis is a diagnosis of the exclusion. So this is a very important piece of information which you should take down. So basically, optic neuritis is a diagnosis of exclusion. So before making a diagnosis of optic neuritis, you have to rule out certain things. So in order to rule out those certain things, you have to do certain tests. So number one is the ESR. And you will be surprised to know that second May they have given the thyroid function test. Thyroid function test. So you have to actually do the thyroid function test also in order to make a diagnosis of optic neuritis, because we have to rule out. It's a diagnosis of exclusion. Then we have to do the anti-nuclear antibodies we have to do. Then we have the angiotensin converting enzyme. This we have to do. Rapid plasma reagent test, that we have to do, as well as the mitochondrial DNA mutation. So you have to do the thyroid function test also. What do you think about blood glucose? Will you do blood glucose for optic neuritis? 1, 2, 3 तो हो गया. So Dr. Stranger is saying that options were toxoplasmosis, posterior staphyloma, tuberous sclerosis, and pigment epitheliopathy, CMV retinitis. Among these 5 options, 4 were given and asked not seen in. Are you sure? इसमें We were having posterior staphyloma, and you said this, and you are saying toxoplasmosis. Then you are saying that we were having tuberous sclerosis. Tuberous sclerosis अगर है तो it is a right one, because tuberous sclerosis will definitely show me, and CMV retinitis will not show me. तो CMV retinitis I do not know. Pigment epitheliopathy can show. Pigment epitheliopathy. If they have given you these options and one was your posterior staphyloma, then posterior staphyloma will be the answer. Posterior staphyloma is not a punched out lesion. Toxoplasmosis में मिल जाएगा, pigment epitheliopathy में भी मिल जाएगा, tuberous sclerosis में भी मिल जाएगा. So then in that case the answer will be not seen in. मेरे ऑप्शंस करेक्ट है? अच्छा चलो ठीक है. तो अब क्या है इसमें देखो, व्हाट डू यू थिंक अबाउट दिस ब्लड ग्लूकोज लेवल? ब्लड ग्लूकोज लेवल करना चाहिए नहीं, उस पर भी मैंने बहुत सारा रिसर्च किया, एंड व्हाट दे सेड इज दैट बेसिकली ये था कि इवन यू नो HbA1c लेवल्स आर फाउंड टू बी हायर इन द एंटीरियर इस्केमिक ऑप्टिक न्यूरोपैथी. तो अगर एंटीरियर इस्केमिक ऑप्टिक न्यूरोपैथी है एंड द पेशेंट इज हैविंग द high levels of glucose, hyperglycemic index is high, then we are having the more poor prognosis of anterior ischemic neuropathy. And they have clearly mentioned the American Academy of Ophthalmology. American Academy of Ophthalmology clearly says that it is a biomarkers to determine the visual prognosis in the optic neuritis. So according to that, you know, all the four options are correct. A, B, C, D, all the four options will be correct. They definitely you have to do MRI brain, you have to do the anti-NMO neuromyelitis optica है, या फिर this multiple sclerosis का MOG glycoprotein है, thyroid profile में they have said diagnosis of exclusion, and even the blood glucose level. So अगर 1, 2, 3, 4 था options में, then you have to go with all four options. You have to do all the four options and the diagnosis of exclusion. बहुत डेप्थ में था. क्वेश्चन नंबर 6 का देखो, सडन पेनलेस लॉस ऑफ विजन था, उसके अलावा RAPD था, विच टेस्ट टू डू, तो इसमें ऑल फोर ऑप्शंस करेक्ट है. प्लीज चेक द ऑप्शंस फर्स्ट एंड देन लेट मी नो. एंड आई हैव डन अ लॉट ऑफ रिसर्च एंड डिस्कशन, उसके बाद ही मैं उस पर पहुंची हूँ. फर्स्ट ऑफ ऑल आई वाज थिंकिंग कि वाई दे हैव गिवन 1, 2, 3, 4 है ना, क्योंकि फर्स्ट उसमें MRI एंड 1 and 2 लग रहा था. But if you look at this protocol, they clearly say that thyroid function tests have to be done to make a diagnosis of exclusion. So obviously you are going with this, and the sugar, blood glucose level is a potential marker for the as a prognostic factor. So you can do that also. So all the four are correct. Okay. Okay. Now another thing which I have a little confusion. Which one is familial and which one is not familial? All of the above था ना, तो all of the above था, तो answer will be all of the above. तो A and B they had given to confuse you, because the most common options or I think most of the people must have answered A and B because they are the most popular options, but the correct answer will be all four. ठीक है. Now you have to tell me which ones are familial. इसमें was there multiple answer correct? Because here also you have multiple answers. Retinoblastoma is also familial, open angle glaucoma is also familial. So I do not know if they had given the multiple answers correct, because here myopia is familial, especially if they are talking about the high myopia, then definitely. So here again your answer will be all. If all the options was given, then your answer will be this, because if you talk about the retinoblastoma, you know that 90% of the cases are sporadic cases in the retinoblastoma, while 10% of the cases are familial. 10% of the cases are familial. So that is there in the retinoblastoma. If I talk about the retinitis pigmentosa, then you already know that the sporadic is the most common. उसके बाद we have familial also. We have familial में most common is your autosomal recessive, and autosomal dominant will give you the best prognosis. This will give you the best prognosis, while the X-linked recessive will give you the worst prognosis. So this is also familial. Then if I talk about the primary open angle glaucoma, this is definitely hereditary, and we have got two genes, optinurin and myocilin. That is also familial. And obviously eye myopias are familial. So if answer was there, if all the four options were there in the question, they had given this answer, then answer will be your all. In this question also you will have all. All tha in the options? Yes. So all of the following was present. ठीक है. Okay. अच्छा, I think somebody has confused this, the clinical features of anterior uveitis. I think which triad is seen in, that is there in the acute congestive glaucoma. ये नहीं है. And finally, this is one question that, you know, I says to everyone ki squint mein you should know the actions of superior oblique, and I even, you know, in the class I have given you the example in the form of superior oblique only, when I have taught you that how to find out what is the actually method of finding out the action of a particular muscle. Then also I taught you about the superior oblique. So we have taught you about the actions of the superior oblique. Let's revise it. Easy tha ye. Superior oblique. Now what is your step number 1? Whenever you have to look for the actions, you have to see whether it's a oblique or it's a rectus. ठीक है ना? So if it's a oblique, then you have to go either for the intorsion or the extorsion as the primary action. If it is a rectus, then either the elevation or the depression. Now because mine is the oblique, so you have to go for this. Then look for the step 2. Step 2 says that superiors are intorters. So intorsion therefore will become my primary action. ठीक है? Then step number 3. Step number 3 says that O for oblique and O for opposite. O for oblique and O for opposite. So superior oblique will cause depression. Superior oblique will cause depression. This will become the secondary action. So you don't have to cram it actually. While the step number 4. Step number 4, the tertiary action के लिए you have to remember the RAD. Recti are adductors. Because recti are adductors, so this is oblique, therefore it will cause abduction. So the tertiary action of this muscle will be abduction. So very conveniently, without any hustle puzzle, without any ratification, you can find out the actions of superior oblique. We have intorsion, we have depression, and we have abduction. है ना? So this is being taught here also. O for oblique, O for opposite, RAD, therefore here you will have abduction, and therefore look at the correct one: intorsion, depression and abduction. Any other question that you think came in ophthalmology? Any other change that you would like to do? No, punched out lesions will not be seen in coloboma. I don't think that is a very good example of punched out lesions, and I do not know whether coloboma was there in the options, but you people are saying that this was there. So it depends. अगर एपिथेलियोपैथी था, ट्यूबरस स्क्लेरोसिस था, टॉक्सोप्लाज्मोसिस था, तो नॉट सीन हो सकता है. नॉट सीन में देन पोस्टीरियर स्टेफाइलोमा. See, posterior staphyloma will also not give you the punched out lesion, and the rubella will also not give you the punched out lesion. That gives you the salt and pepper retinitis, right? Coloboma does not give you the punched out lesions, but अगर rubella भी था तो I think the better answer is rubella, because salt and pepper retinitis होता है, तो it is far away from the punched out lesion. Coloboma में फिर भी we get a circular one, and posterior staphyloma is again a answer, क्योंकि posterior staphyloma में भी we do not get the punched out lesion. So I think there is some gadbad in the options. Maybe they have given the by mistake, not a problem. You know the right thing now, so be prepared for the right options next time. Okay, so I think we have done all the questions. Tell me if any question more was there, because this is the maximum that I couldn't extract from you people according to your memory. And as far as I see, I think we are having the right questions with the right language and the right options, most of them. And we have done with all the questions. Thank you so much, guys. And I hope if yeah, final answer will be Rubella here. I think we have done with all the questions, and please keep notifying if you find any other question. Agar memory may you get any other question of ophthalmology or any other change you would like to do, then definitely tell me. I am waiting for your feedback, and keep studying. Okay, guys, no matter what you did, everything was there, but you have a bigger paper now, so don't focus there कि ये गलत हो गया और वो हो गया. You have got a better chance, and I think you are lucky enough that you got to know your mistakes, you got to know your weaknesses, and you can improve on. So those people who have some problems and do not get to know actually have real trouble in the exam. So I think you are lucky enough, you got to know what were your weaknesses. Please now start working on them. Okay, whatever were your mistakes, whatever happened, let it go. Now pull your socks and work on your weaknesses, whatever was there, so that you do not commit the same mistakes, you do not repeat your mistakes, and you come up all with your flying colors in your neat paper. So thank you, and happy ophthalmology.